Well, hello, everyone. It's really an honor to speak to this group today about the future of health reform and how home-based care providers are going to play a role, particularly in accountable care organizations and really in accountable care more broadly. You know, as we look to the future of healthcare reform and overcoming the challenges that we have, I really believe that home-based care is a key to the future. It's exciting to see the things that you can provide, and we will be talking about those in a little bit farther in the presentation. And even a little bit beyond that, I will say that as I interact with stakeholders in the healthcare industry, I am a consultant, and we do talk with providers and payers and all types of professionals and even consultants. I've really found that professionals in the home-based care are some of the best-hearted. They just seem to really be in the business for the right reasons. So it's a privilege to be here. I hope that I can provide some insight into what's going on in healthcare on the macro level. And I want to specifically give you all some advice and things you should be aware of as you make your strategic plans for the future. So my name is John Poelman. I'm a senior director at Leavitt Partners, where I cover healthcare policy, I cover congressional and regulatory activity, and payer and accountable care. I used to work in D.C. for the Department of Health and Human Services, primarily on quality measures and healthcare transparency initiatives. And I've been with Leavitt Partners from the beginning. And to give you a sense of what Leavitt Partners is, some background, Leavitt Partners started in 2009. It was founded by the former Secretary of the Department of Health and Human Services, Mike Leavitt. Secretary Leavitt was there for 4 years. Before that, he was the administrator for the Environmental Protection Agency, and before that, he was a 3-term governor of Utah. He's brought a lot of great leadership in those years he had at the Department of Health and Human Services, also as governor. You know, a lot of state services that the governor gets involved in with healthcare. So as we've come together and started this company, we really grew up, interestingly enough, at the same time the Affordable Care Act grew up. I think about 2009, that's when we were starting to see legislation. And we've really been helping companies since then understand how the healthcare industry is changing. But it's important to recognize that the Affordable Care Act is only a piece of what is going on in healthcare. And so we've really focused our business around a few different areas: insurance market reform, you know, the payer activity, insurance exchanges, Medicare and Medicaid, just broader health policy reform, and then accountable care. Accountable care really is one of our primary focuses and something that's been increasing more and more in the last few years as the movement has gained traction. We've learned a lot of what's going on, and really we've seen this movement come from theory to reality. And of course, there's a broad future. I want to just mention one thing that we have that's pretty big news on our side, and that is we decided to combine, just this month, we announced the combination of our Healthcare Accountable Care Intelligence Center with Brookings Institute has been hosting the Accountable Care Organization Learning Network, and we formed the Accountable Care Learning Collaborative. This is managed by Leavitt Partners. We're excited because we're really bringing together it will be the largest accountable care think tank, essentially, if you want to call that, or just learning collaborative, where all different types of industries can come together. The idea is that we get payers and associations and pharmaceutical manufacturers and a lot of ACOs to really understand what their different roles are together. I will mention that we have a lot of members, but we don't have as much representation of home-based care among our current members, and this is an important perspective. So we're going to be recruiting. We'd love anyone who's interested to reach out and get some more information on it. So I want to cover really 3 areas today, and we'll start with just what is driving healthcare reform. I think that's an important foundation because it's what's driven it to now, and it's what we'll see continue to drive it forward. Of course, I want to give an overview of what's happening in accountable care. And then finally, what should home-based care companies be doing now as you watch this movement, as you prepare and see things continue to move forward? So just to begin, it's important to think about and recognize what the goals of healthcare reform. You've been hearing healthcare reform talked about for a long time. The Affordable Care Act is the most recent thing. You can go back to Hillary Care, Medicare, Medicaid. If you keep going back farther, President Truman actually was very involved, and everyone has been involved. And if you think about the evolution, really you can see what healthcare reform is focused on is three areas. One is reduced costs, increased access, and the improvement in quality. And just to say something briefly on each one of these, and then to drill down into the cost quality, just on the cost in general, the United States has over 17% of GDP is on healthcare. It's the highest share of almost any country in the entire world. And this has been a growing concern. It's been growing. Its trajectory is to grow, because if you think about those who are paying for healthcare, these are states, this is the federal government, these are employers' compensation, these are individuals. And really, with the cost going up, all of them are having greater strain, and it's harder for them to perform their other duties. It's crowding out other opportunities and services they provide or other things they want to do. And it's just become, with so much pain across the board, it's been getting more and more attention. If you look at quality, it's hard to define U.S. quality. I think a lot of people say we have the best healthcare in the world, and in some areas we do, and for some people we do. But if you really look on an international level, we're ranked 27 out of 34 in life expectancy. And there are other stats that are a little disappointing when we think about it at national level. So while we have high quality care, for some it's really not there for everyone. There's some system-wide deficiencies. And then access, and what I mean by access is really, this speaks a little bit more to access to health insurance. And health insurance doesn't mean you can actually see a provider, but there's supposedly more of a connection. The Affordable Care Act was really about access. There were 16 million uninsured Americans before the ACA. A recent number came out that projected more like 11 and declining. And this makes sense that the main part of the Affordable Care Act is, insurance can no longer deny people for pre-existing conditions. You have these insurance exchanges where lower income individuals can receive premium credits to afford insurance. Medicaid eligibility expansion, which is now optional by states, are happening a lot. And then employer mandate, where employers, of certain sizes are required to provide insurance, or they face a penalty. All these were efforts within the Affordable Care Act that really focus on increasing the level of access to care. Now, there's parts of the law that are often overlooked, and this is in delivery system reform. There really is key components of the law that are about reducing costs and improving quality, and they've been making a bigger difference along the way. It's generally more bipartisan, although you don't really hear it talked about by Congress or in the headline news, because and these are important things. It's just not great political talking points, but they're great initiatives. A couple of these things to be mindful of. One, the Affordable Care Act created the Center for Medicare and Medicaid Innovation. This is really innovation is its goal. This is within CMS where Medicare is run, and this is where you see a lot of the experiments with accountable care organizations going on. You also see bundled payment initiatives here, a lot of innovation grants going to private entities who are trying to find solutions to improve accountable care. And it's really caused CMS, and we've really seen a lot of activity on a federal level to change, to transform healthcare. They feel like they're a great player that can train not just for Medicare beneficiaries, but for the whole country. Because as you move the needle for providers in one payment area, it's more likely that they're going to follow under commercial contracts or other populations. CMS recently came out with a goal that by the end of 2016, they want 30% of all Medicare payments to be in alternative payment models. So that includes ACOs, that also includes bundled payments, includes medical home, other alternative payment reforms. So that's 30% by 2016, and by 2018 they want to get 50%. And I know, they have other projections, but these are pretty big goals in a short amount of time. And just heard from the director of CMMI, Patrick Conway. He said, he really feels they're on track, and they might even exceed it. Now, there's activity in the private market too, and I'll show you a little bit more of that in a moment. So, an important thing to also recognize, though, is that health reform is really not a new thing. If you look at where we are now, and on this slide you can see, the start of 2015. If you just look back, even starting with 1990, and there was activity before then, of course, but the managed care kind of came in as this effort to control costs. We're seeing costs going up in healthcare, and so you brought in some of these insurance companies who are really regulating the volume of care, and we know what happened there. It still exists, but it's been going down significantly. If you look at the next decade, that's really when you started combining quality and implementing quality and cost, and that's a very important differentiating aspect of accountable care versus managed care. A lot of it is incorporating quality measures to show that it's not just reduction in care, but it's more efficient care, it's better care, and it's through that more efficient care that you lower costs. So that defining quality period was really where a lot of demonstrations happened. And when I was at the Department of Health and Human Services, this is a stage in which Mike Leavitt was there. There were a lot of demonstrations going on there to try and prove these things out, which then went into the Affordable Care Act, as coming into actual law. So we're at a stage now of emerging value. We've figured some of these things out, and it's starting to, we have some proven models, and now we're entering really the how-to phase, the scale. Really, how can you tactfully actually implement these things, not just in certain types of organizations, but across the entire industry. And this is what we see happening over the next 5, 10, 15 years. So just stepping back then for a moment, I guess, there's your context of drivers. So I want to talk about really what is accountable care. And I'll put 3 parts here, and we divide them out by structure, processes, and outcomes. So first, you look at, I guess maybe a definition or a definition of accountable care is really an entity that is financially responsible for the health needs of the population, can coordinate and oversee the clinical provision of care across the continuum of healthcare services. And then third is really being accountable for measured outcomes relating to cost and healthcare quality. So this is what an ACO is, and this is why it can be different than a managed care organization. We know there's a fragmented delivery system and suboptimal care, and the current payment reform or payment system does not incentivize high quality care. So this is sort of this effort and this definition of how things can be differently. Now, although this is kind of the concept, there are so many different types of configurations out there in the healthcare industry that we talk about accountable care or even accountable care organizations, but that doesn't mean there's one single model. Accountable care does not dictate specific provider configuration. So Leavitt Partners got into this, and there's a saying, you might have heard it, and I'm kind of tired of hearing it. And people say, if you've seen one ACO, you've seen one ACO. And that's kind of true because each has their own unique aspects and attributes, but we really feel that you've seen one ACO, you've only seen a category of ACO. So over the past few years, Leavitt Partners tried to drill down into this theory to say, can we compartmentalize? Can we sort of classify the different types of ACOs that are out there? And what we want to do, and what we are doing, is figuring out these different models. We can measure which ones are most successful, and then we can help those building ACOs or intending to join ACOs to figure out what role they might play. What is a successful configuration? So over the past few years, we've conducted and continue to conduct interviews with people who are leading these ACOs. And we're asking them to describe their structures and the nature of their partnerships and what care they directly oversee versus the things they partner for, et cetera. So after analyzing a cross-section of ACOs across the U.S., we conducted a cluster analysis and determined that despite an infinite amount of variation due to market and historical circumstances, there are really 6 main configurations or types, if you will. And so these are what we call our taxonomy of accountable care organizations. Each brings with them a different set of advantages and challenges, and consequently a different set of needs. Understanding the difference between these types really helps the industry build the solutions that are truly useful. So just looking at this, the color coding does have some significance. You see in the top left where the full spectrum integrated care. This is like a Kaiser or a Mayo or Cleveland Clinic. These are entities that really, they have the hospital, they have the physician group, sometimes they have the insurance company also as part of it, but in this sense, they're all under one system, and it's easier for them to coordinate care because they really run the whole show. The next 3 are physician group oriented, and we know there's a lot of different types of physician groups, and they are aligning themselves in different ways. So the independent physician group, this is just a single entity that provides, they're directly providing the outpatient care. You have physicians that are getting together in sort of an alliance. So this is multiple organizations that are coming together to provide the outpatient care. And then you have expanded physician groups. So this is a physician group directly provides the outpatient care, and then they contract for the inpatient care. And the last 2 moving to really just the hospital focus. You have an independent hospital. This is a single organization that can directly provide inpatient care, or they get into an alliance. This is multiple organizations. One is directly providing at least that type of inpatient care. So this is really, as we've done these interviews, as we've tracked all the ACOs in the country, this is what we discovered. There are some different combinations here, and as home-based care entities, I think this is an important thing to look at as you think about with whom to partner. You can see how different ACOs are forming and where you might fit in best given your market. Just a few specific data points on these taxonomy types. I think we'll share the slides here, and so you can read this a little bit later in more detail. But they do vary, of course, by number of ACOs and the number of lives that they're each serving. There's some, you can see that the hospitals are a little fewer on the number of ACOs, just based on the number, proportion of hospitals versus physician groups, but the lives are different. Now, you'll notice in this that you might have a lot of ACOs, but not a lot of lives, and it's important to recognize you might have a hospital or a physician group that is an ACO or started an ACO, but that doesn't mean all of the care they're providing is under risk-based payment. Sometimes we're seeing ACOs that are, these provider groups as ACO might, as an entity, see 10,000 plus patients, but they only take risk for half of those or less. And so you can see that there's, we shouldn't, just because you hear there's an ACO in the area, it doesn't mean everyone is being treated as, every patient is being treated as an ACO. So just want to talk about, having that context, want to look at the overall trajectory of the number of ACOs and the lives. So this is this starts in 2011. So we tracked a little bit before this, but this is where you kind of get a significant number of 81 ACOs. You can see that number climb, now where we're at 757. There's a couple steep bumps here, and what those are the Medicare, as they've created their ACO program, they announce these ACOs in rounds. And so there will be, 100 ACOs that'll be formed at one time as Medicare hits another round of ACOs. You can see that pattern in here. But even in between those, you're seeing ACO growth, and those are because these are commercial ACOs that are happening as well. It's interesting to look at these numbers by sponsored type, and so what this refers to is, you can think back to that taxonomy to a degree, the physician versus hospital, but these are the entities that really let out saying we're going to start an ACO. Maybe they are the primary ones, and then they contracted. So these are the leaders of the organization. You can see providers and hospitals really are neck and neck along the way. At the beginning, you saw hospitals come out of the gate higher, and that makes sense just because they have more capital. It was easier for them to start these things up. Physician groups, though, have a great opportunity, and they recognize that if they can keep patients out of inpatient care, they have a really great opportunity to reduce costs. So they have escalated, and CMS is partial. They really want provider-led ACOs, and they've been encouraging those and making, wanting to have as many as they can, and so they've made some progress as well, and you can sort of see how that's lining up. The insurers are also doing it, and there's some other entities along the way that form them. There's also geographical variation. So if you look at different states, and some of this is related to population concentration, but some of it is, we've seen a lot of managed care organizations like in Southern California. It hasn't been as hard for them where they still exist. You still have a lot of managed care activity there. It's been easier for them to transition into an ACO model, or at least transition a part of their population into an ACO model. But what's important to notice here is that it's not everywhere in the country all at once. There are places that are hotspots, and there are places that are less. Another reason for that is we find there's competition, right? If you're a system or provider group in your market area and there's another ACO forming, you may feel threatened or competitive, and you will then form your own. So we see a little bit of there's a synergy there. You can drill down a little bit more on this, and going by HRR growth, you see, especially in California, you see the southern part has more. There's variations really across the whole country. This is an important slide, and I won't show it again, but you've referenced it, that when you think about your market and what's going on in your activity, the activity in your area, it's important to be paying attention, right? You might be in a white spot, or you might be in a dark spot, and knowing where your market is critical. I mentioned the lives area, so we've created a model that projects lives. Not all the information is public. You can see the trend line is similar to the overall growth, but kind of where we are, we're in between 20 and 25 million at this point, or last year. And what that gives you a sense of, again, is you have a lot of ACOs, not all of them are doing the same number of lives, but it's a pretty significant chunk that is growing. Similarly, geographically, you have variation just looking at lives by state. What I also want to show, and this is where Leavitt Partners data has been unique, the Medicare, Center for Medicare and Medicaid Services has been very public about the ACOs that they sponsor, state sponsor. So you can see that 394 are those that are exclusively a public program, and most of those are the Medicare ACO program. The red, though, is where we've been able to track enough of these private contracts. These are ACOs that are not having to abide by the specific rules of Medicare. They can come up with their own creative arrangements, and you see a lot of ingenuity and different types of payment models, experiments that are going on in that category. And then this lighter blue, 113, is where there's overlap between those two. Right? We're seeing, and this makes sense for a lot of ACOs, right? It's hard to live in two different payment incentive programs. They talk about this transition of going to an ACO as like having one foot on the stable land and one foot in a canoe. It's tricky to make that transition, and if you're going to do it, the faster the better, assuming you have the confidence that you can't keep keep going. Also within, I mentioned there are these public programs, the Medicare shared savings ones, of course, there. We are seeing growth in the Medicaid. States are leading out on their own initiatives with their own managed Medicaid programs, often how that runs. But with that growth, we're seeing more experimentation. Again, they can do different things, and they just have a unique population that's different than Medicare, and there's some opportunities in that population for some savings that you don't see in other places. Also seeing that on state governments, there's, the number are not great, and these are states who are either have an ACO program underway, multiple ones, and those that are in the process of doing it. We expect, of course, this map to be covered in more and more over time. So where I want to get now, and maybe this becomes more interesting to you, is just what is the impact on home-based care? What does it mean for home-based care? My first point, I guess, of this part of the presentation is just to help everyone understand that I really think you should take this movement seriously. Things in healthcare are changing. Everyone will be affected, and care will just be provided differently and by different entities. There are people who are organizations that are sort of entering into spaces of care delivery that they weren't traditionally doing. And so it's not only watching, I guess the point of this is everyone needs to change. So Leavitt Partners actually worked with the NAA in March, knowing that this is a big issue, and wanting to wrap our minds around what this means for the home-based care industry. So in March, we brought together, really in a roundtable format, 20 people that represented ACOs, skilled nursing facilities, or other home-based care companies, insurers, associations, electronic medical records, and other technology vendors. Sit around the table, people who really get this industry and know where things are going, to talk about what are the challenges for transitioning for companies in the home-based care industry, what are the emerging and promising models. We've seen some fantastic innovation. We have some presentations from those who are very progressive in figuring out unique attributes that home-based care companies have that can really make drastic improvements in quality and reductions in cost. And then we came up with some recommendations. These are the things that I want to share with you. So just starting with just some advantages and disadvantages, where I think you can be thinking about this, and then we'll go into some recommendations. So on advantages, it really speaks to home-based care has one of the greatest opportunities to reduce costs and improve quality of any other provider organization, any other provider of care, professional provider of care. Through efficiency, better care, higher quality. When you think about global savings is where accountable care is going, there can be great creative programs which can reduce care, and if you kind of take off the barriers or the reins of payment models which were constrictive in only providing care, only being compensated for limited number of services, not all of which, when there are others that might make more of a difference in overall care. So if you, and a few reasons why you have this, you all see the patient in a way that no one else does. You have a relationship that no one else does. My dad actually recently, about a year ago, passed away from Alzheimer's and Lewy body disease. It was a 5-year progression. My mom, when he was first diagnosed, her goal was to keep him at home. That was the #1 objective. She knew that's where he would want to be. She knew it would be where we would want him to be, have a better experience. And so that really became our family goal. And it was so amazing how the home health professionals and eventually the hospice professional, really that became their goal too. So we worked together to creatively think through every scenario, every threat that might come that could take him into an inpatient facility, and how we can avoid that. And of course, the consequence of that. You compare the cost of a day of home health compared to a day in a hospital or even just a skilled nursing facility. And the reduction is significant. And if you multiply that across thousands or tens of thousands of hundreds of thousands and millions of patients, then you're really seeing significant drivers of cost reduction. And this is really just where you can do things where other people can't. Now, there are disadvantages and threats as well. And when you think about they're important to recognize. One, if you look at that taxonomy that I just showed earlier, it doesn't show a home-based care company leading it. Or we're looking at hospitals, we're looking at integrated delivery systems, we're looking at physician groups. These are the power players in a market. They're the ones that are moving the needle, moving things forward. So there is some weakness in the home-based care market in just their ability to negotiate, their leverage. Where you have markets where competition is strong in home-based care, you have a higher likelihood of being pushed out, or home health in general can just become more of a commodity. You will not be able to maybe participate in the risk-based care unless you can show something unique. You can provide care in a better way, and I'll talk about it in just a moment. Another disadvantage that generally is in the home-based care industry is a lack of quality and performance measures. I mentioned a key pillar of accountable care success is improving quality. And there has been a great initiative to create quality measures and that demonstrate, efficiency. That is the way healthcare should be delivered, and that's been going on for a long time. And now we're into thousands of quality measures. Even still, a lot of those are inpatient-based or outpatient-based, but or physician-based. But there are not nearly as many that focus on home-based care. It's hard to demonstrate from home-based care companies just why they are uniquely valuable, and there's just no standardization for these measures. Another disadvantage that home health companies have, home-based care companies have, is technology. Another principle of accountable care is electronic medical records, and this can be for coordination, care coordination. It can also be for data analytics. You know, and we know that these are expensive platforms. They can take a long time to implement. There's not, it's hard to see the return if you're a smaller group. So it's usually the physician groups of the hospitals that are running these things, and they need to share. The fourth disadvantage I'll just throw out there is, and this is not your fault, but just there's less of an awareness in the home-based care companies of the changing landscape, right? And DNA, I think, is helpful in providing that perspective, and I think associations are a great way to go. But consultants are expensive, and larger organizations have an ability to invest in monitoring and strategizing for change, looking at their markets, because markets are going at different paces, and it's really just harder for these entities to keep their finger on the pulse. So I want to offer 7 recommendations that I think every home-based care company should be thinking about as they look at the accountable care movement and how to go forward. Now, the first is to know your market. And the way to do this is there's not a whole lot of sophistication, but you just need to keep your ear to the ground. You need to network, know what your competitors are doing, know what advantages they have, know what entities, what accountable care organizations are doing. Obviously, you're in the healthcare community locally, and knowing what activity there is important, just being aware of what's going on. The second part is being a part of the conversation of what is going on in accountable care. If there is movement of accountable care already, talk with those entities and see what value you can offer. What are the things that you can contribute that will help them improve quality and reduce cost? You might find them very interested, especially if you can come with a specific value proposition. If there isn't activity in the area, or if there is but you're being blocked out, initiate the conversation. As far as being blocked out, I mentioned earlier how there's competition. If one ACO pops up in the market, others seem to follow. If you see one and you're not involved in the first one, talk with the other providers in the area and see if you can be part of developing another one. Those who are progressive, because they may feel threatened, and you can even lead or initiate those conversations. They're definitely important to be at the table. So the third then is thinking outside the box. And this goes to the insights that those who deliver care at home just have that other people don't. They know the patient, and they see firsthand what challenges they might have. They know their personalities. They can see risks that even electronic medical records or any data analytics platform cannot see, would never be able to identify. The home-based care companies do. So think about ways in which you think your employees can identify risk and reduce costs by providing certain actions. We've heard all types of examples of this. We've heard of, people, ACO buying an air conditioner for a patient because of, heat problems that were in the home, and that's only someone a home-based care company individual would know. I heard a story just last week about an ACO who bought a microwave for an elderly woman in her 90s because she was short and she was cooking her hot dog every day. It was just what she loved for lunch, and she was doing it on this on her stove. It was really quite dangerous as far as catching everything on fire, about her hurting herself. And they found if they just bought an inexpensive microwave, they reduced that risk significantly. Again, these are things you can't find in data analytics, and this is something that, perspective that your groups can see, that your employees can see that no one else can. So the fourth, I'll say, is demonstrate value. There are not a lot of standardized metrics out there, and there are some, we talked about quality measures and the importance of those. There are actually a few quality measures in the Medicare ACO program where home health can make a direct impact. I think BNAA has identified some of these. These are a must. Look at these quality measures and see how you can be proficient in affecting them. And in your conversation with other ACOs and the entity you're developing, find ways, be sure that you can prove that you can influence that. You have the resources, you have the orientation, the strategic positioning to do that. There are other, there's a lack of other metrics. I mentioned that. So are there any other ways, do you think, are there any other ways in which you can demonstrate value that you have that your competitors don't? Can you demonstrate some reduced readmission rates? Make them defendable, make them quantitative to whatever degree you can. It reminds me of interviews. I'm sure all of you have done interviews in one point or another, and people come in with resumes or you see resumes, and there's that difference between the resume that comes in of the individual that says, at their last job they increased revenue 25% versus the resume that says, I have good leadership skills, good managerial skills. Something quantifiable can be valuable for ACOs that are really looking at their bottom line. And if nothing else, patient satisfaction is often a proxy for specific outcomes quality measures. Obviously, that's a goal that you all have for your patients, and it's an important part of general quality and improvement and measurements that we're seeing. The fifth one, mind the networks. ACOs, the whole point of ACOs is to have care coordination and reduce costs, and really the only way that they can do that, the most effective way they can do that, is by knowing exactly where their patients are going and having influence on those entities. So they're narrowing networks, and we're seeing this a lot. I mean, almost every ACO will start by educating the lower performing institutions, and so they can do this care coordination. Patients and ACOs, that means that they will have more limited networks, but we're seeing consumers are more and more okay with that if it's tied with cost reduction. We've seen on exchange markets, we're just seeing a general trend change as individuals becoming more cost sensitive. They'll trade that off for networks, and that's a perfect opportunity for ACOs. Be mindful of where you fit in these networks and position yourself the best you can. Consider all strategies. Now, this isn't an area that I'm an expert on, but if you look at what's happening in the industry broadly, you are seeing a lot of mergers and consolidation. And I know all of you are seeing that ACOs form either by buying provider groups or contracting. You know, there's hard connections, and then there's sort of affiliation. Both can succeed, but there will be opportunities to buy, and I just think you should be looking in your market specifically, watching your area, and see if there's a reason you should be positioning yourself, and just keep open. The landscape's changing. Don't be caught off guard. And that really leads to the last one. I put pace yourself, and what that really pertains to is just knowing when to enter the best you can. Again, goes market by market. Think of that map I showed earlier of the regional variation of accountable care. I heard an individual talking, actually I think this was at a tabletop, said, you know, you don't want to merge you're coming on an on-ramp. You don't want to merge onto the highway going 10 miles an hour nor 100 miles an hour. You need to find that right speed. Starting up, being involved in an ACO can be expensive. We've seen entities who have really hurt themselves because they've invested in very expensive electronic technology very quickly, and they haven't been able to see the returns fast enough. There's either other ways in which you can do this, partnerships, other discount methods. Minimize your payment configurations, right? That's sort of 1 foot on the land, 1 foot in the canoe. Try and keep those as harmonious as you can. Play a little around with it, bring some confidence, and then go a little farther. I'll end with a story I think that sort of relates to, and this is one that Secretary Leavitt, our company, often tells, and I don't know if it goes back to the story of Cinderella. So the story of Cinderella, you all know, and this is a slight variation, that she gets this opportunity to go to a ball, and she's having a fantastic time. It's an environment in which she's enjoying herself, and you look at this, they're all Cinderellas, and the metaphor here is these are really all people living in the old world. This is a fee-for-service payment world where, you know, the wine is flowing, people are, you know, the men are handsome, things are going well, but there is an approaching time, and that's midnight. And the tricky thing for Cinderella, and I guess in this example, isn't paying attention or don't know when midnight's going to occur. And at that point, if it comes too early and people are unprepared, there can be this mad dash for the door, and it might be sooner than people anticipated. It might be bad time. So, you know, just overall, I think the important point to this, and as you think about your strategy, is don't underestimate the magnitude of this change and how much it will change the industry. At the same time, be careful with the pace. Don't move too early, don't move too slowly. And that really comes down to individual market observance, getting to know the stakeholders, the other players in the industry, and being networked in that regard. I'm cheering you all on. I still believe that really home-based care providers can make one of the biggest differences in how healthcare is delivered in this country. And we talk about the need to reduce costs, to improve quality, and even which ties directly really to increasing access. You all have an opportunity to have a tremendous impact, and I want you to succeed. I want you to be providing that care that really will make healthcare better for everyone. So I applaud you for what you're doing. I cheer you on, and I wish you luck at these iterative stages. And feel free to reach out to us if you would like to ask any more questions, or if you think we can help you in any way. So appreciate your time, and hope this has been worth your time and worthwhile. And